So far in this series, we've covered what dementia is, how to normalize screening, how to diagnose dementia, and now we will discuss adapting your assessments for patients with barriers. Hi, I'm Jessica De Leon, behavioral neurologist. So let's say you typically use the clock test to screen for dementia, but a patient comes to see you who is vision impaired. Well, it's going to be difficult to do the clock test, right? There is no one perfect cognitive or functional screen that fits all people from all backgrounds, and considering many people have communication or practical barriers to being screened, we may occasionally need to make modifications. Here are some examples of common barriers. If and when you encounter these, keep in mind that our assessments of cognition and function can be flexible if we keep in mind the goal, to do our best to understand function and cognition. Will you see more than one of these barriers in your patient? Probably yes. One strategy when faced with a barrier is to do your best to establish a baseline and monitor for changes over time. How might we do this? Focus on collecting a very thorough history and other collateral information. Consider what has changed in the person's cognitive baseline. Is there a decline? Is there a decline relative to their perceived baseline? How is the patient functioning day to day? Is there a decline relative to their perceived functional baseline? If you cannot determine at that moment if there is a decline, then you have a baseline and follow-up and monitoring is appropriate. Let's talk about some specific scenarios now. Let's say you can't communicate with your patient because, for example, there is a language discordance. This is often very obvious, but if you don't speak the patient's language, make every effort to get a certified in-person interpreter, not friends or partners. When an interpreter is unavailable, it is acceptable to involve relatives to help with communication issues for screenings with the permission of the patient and the relative. Let's say the person you are seeing is hearing impaired. This is very common. Try to maximize the ability to hear, for example, by keeping a personal amplifier like the Pocket Talker in your clinic. Let's say you can't communicate with your patient for some other reason. This is when we might adapt how we collect history. And how might we do that? Try asking if they have a relative or friend or close contact you can talk with to obtain a history as best as you can. If a patient lives in a facility, ask the patient if you may also obtain information from facility staff. If that isn't possible then, or anytime in the future, note this in the chart, including the reason. Try to get a general impression of the patient's cognition and function by observing the patient's abilities in performing tasks, answering questions, and their behavior. Document these observations in the chart as a baseline for a follow-up encounter. Let's say you have a patient with limitations in gait that precedes their cognitive complaints. In other words, they might have difficulties with activities for daily living at baseline, not due to new cognitive complaints. In this case, the questions asked about activities for daily living, instrumental activities for daily living, would need to be adjusted to their disability. You might ask, I know that your left side was paralyzed due to a stroke and that your partner helps you get dressed. Has this changed at all? For patients with learning challenges, either due to developmental differences or low literacy, it may be difficult to find a valid cognitive screening tool. Drawing a clock, for example, may be extremely challenging at baseline for someone with low literacy and would give you a false positive. In this scenario, establishing a baseline is always helpful, even with screening or assessment tools that are not ideal for your patient. Here are some general strategies. Pick one test that is reasonably appropriate and use this test as a baseline. Repeat annually to monitor change. Choose a cognitive screening tool designed for patients with low literacy. Several are provided in our resources. When in doubt, refer to a neuropsychologist if available. Your patient may have a history of cognitive testing in their record, and it's worth asking if and where they have been seen before. Functional assessments are often different for people experiencing homelessness. Think about what activities for daily living make sense for them and modify. For example, housework and meal preparation may not be as relevant. Ask what they do to get through a day. Has that changed? Do they need more assistance from others? If they are in a shelter or transitional housing, try to speak with people who see them with some frequency for their collateral report. What happens if someone is just generally reluctant? Patients may decline an assessment for a variety of reasons that they may or may not want to share. Does your patient appear concerned about their cognition, but also hesitant to talk about it? Do you notice that your patient may or may not have insight into their cognitive and functional deficits? Sometimes in this situation, I'll try to move on to other things, like the neuro exam or asking about medications, and then circle back to questions about cognitive symptoms once we've built some rapport. Or I'll ask what they're hoping I can help with, or I'll ask what they enjoy doing or how they spend their day, and use that to get some information about functional status. In this scenario, you might try finding a trustworthy friend, relative, care partner from whom you can get collateral information regarding the patient's cognition and functional abilities. It's okay to spend as much time as necessary, over as many visits as necessary, to build rapport with your patient before diving in. Consider dividing the components of an assessment, cognitive screening, functional screening, etc., into different visits spread out over weeks or months. The bottom line, be flexible. The important thing is to just get started and do your best to establish a baseline.